So, do we have Dr. Sonali Prasad? So, she will be presenting her paper on microbial keratitis and antibiotic sensitivity patterns, a retrospective analysis in Central India.
A very good afternoon. First of all, thank you AIS for giving me this opportunity. So I'm going to talk about the microbial keratitis and antibiotic sensitivity pattern, a retrospective analysis in Central India. So microbial keratitis is a suppurative inflammation of the cornea, and it is leading cause of corneal blindness. Roughly of 1.5 to 2 million cases are globally affected because of its rapid progression. It is mostly caused by bacteria, virus, fungi, and there is a regional variation in the predominance of different organisms. This can be due to the influence of risk factors or climate or geographical variations. So it is important to analyze the recent pattern of etiological agent causing infective keratitis and their sensitivity in a particular geographical area. This will help us in making an evidence-based decision in choosing the appropriate empirical therapy. So aim was to report the infective keratitis, microbial profile and antibiotic sensitive pattern at tertiary part of Central India. It was a retrospective study conducted for 2 years, and a proper institutional review board was taken. So we define infective keratitis as patients having corneal ulcers with loss of a corneal epithelium and underlying stromal infiltration and suppuration with signs of inflammation with or without hypopyon. So all diagnosed cases of severe keratitis were taken from the OPD basis. We excluded keratitis of sterile, neurotropic or autoimmune nature, and patients who could not come for follow-ups or concurrent endophthalmitis or nil microbiological interventions. So after a patient came to us, we filled a standard form for documenting his ocular history of trauma, contact lens wear, corticosteroid use, systemic illness, corneal finding, including the corneal diagram with socioeconomic details and predisposing factors. We did a corneal scraping and culture for all the patients, and the sensitivity was checked with the help of Vitek2 machine, which is an automated photometric system, and it gives results in just 6 to 12 hours. No financial disclosures. So results, out of 455 patients, 143 were male, and the culture positivity was seen in around 233, that is 51% of the patients showed culture positive. Pure bacterial was seen in around 35 patients, and 62 predominant of our growth was purely fungus. Among the bacterial isolates, the gram negative was seen in 52% and gram positive was seen in 47%. Pseudomonas was the most common bacterial, gram negative bacteria, followed by Klebsiella. Among the gram positive, we have Staphylococcus followed by Bacillus and Streptococcus. Fungus was the overall most common organism, with unidentified hyaline fungus being the most common organism. Coming to the sensitivity pattern, the Pseudomonas was 89% sensitive to colistin, with 65 to 75 resistance to other antibiotics. Staphylococcus was 100% susceptible towards Vanco, imipenem, and 65 to 70% resistant to other common antibiotics. Streptococcus was mostly 100% sensitive to a lot of antibiotics, with 66.67 resistance to levoflox and 33% resistance to moxifloxacin. So coming to discussion, clinical outcomes in microbial pattern and epidemiological pattern may be different in different parts of the country, also between the different countries, between the geographical areas. So it is very important to analyze a recent pattern of etiological agent in your area and formulating an evidence-based decision on choosing the antibiotics. So there has been multiple studies from South India documenting their most common organism and their sensitivity pattern, studies from Eastern India, studies from North India. This was a study multicentric where our institute had also incorporated some data, and Staphylococcus was again most common. So limitation of our study, it is single center study, but still patients mostly were poor compliant and had been treated earlier by non-ophthalms and low socioeconomic patients. The Vitek2 machine is not an exclusive ophthalmic use, it is for a general medicine use. And so conclusion, although it was a single center study, the data that we had definitely provide a better understanding of the current pattern of infective keratitis in the rural setups, formulating a structured protocol. So unnecessary, it will also prevent the unnecessary use of antibiotics and further resistance. Thank you.
How different is the this thing observation from South Indian study and that is the Aravinda study and
sir, mostly they also sir, we had Staphylococcus and they mostly have Streptococcus as the most common gram positive bacteria. Also in fungus they had Fusarium and Aspergillus most common, which was a little different.
Talking about Aravind study?
Similarly, all the South Indian papers were quite similar. We, irrespective of other studies, Streptococcus was more common in our setup, more than Staphylococcus. That was a difference, sir. And the sensitivity pattern also, the Staphylococcus that we had was more sensitive to other organisms, other antibiotics, sir.
How many cases you have done culture and how much?
Sir, 455, total 455, out of which 235 were positive, almost 51% were culture positive and 49% were culture negative. So out of the positives, sir, 60% were fungus.
And most common was like?
Overall, most common was fungus, sir.
What empirical treatment you want to start with these cases?
So normally, what we do it in our practice, we either, first of all, depending on the microbiological, we wait for the scraping. Not culture culture is not done in every patient that we have in the OPD because the workload is too much. So depending upon the scraping, we give moxifloxacin now only. For the bacterial and for the fungus, we start the patient on netamycin, sir.
I think this is a very complex, like microbial keratitis
Yes.
is not like
Yes.
something which anybody can define.
Yes.
So we'll, yeah, yeah.
So unlike staph and strep, they are practical common cells.
Yes, sir.
So where do Pseudomonas multiresistance coming from?
Yes, sir. We have actually faced that issue a lot in some of the patients. Sir, actually we had also published this paper, so it has a table with all the organisms and particular sensitivity, some of the organisms that were resistant to most of the antibiotics. So we had to make formulated, for example, gram-negative, we had to start colistin or other antibiotics that the patient was coming sensitive to. A lot of patients were resistant to most of the antibiotics. So, but those cases were quite less that we faced. Yes. Most, sir, in our population, it was agricultural workers, male agricultural workers. Yes, sir. 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 Yes, sir.
और नहीं है ये लोग नहीं है क्या?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. That has mostly happened patient who had multiple layers of treatment previously. A cocktail treatment was started in those patients previously. So those patients when landed up to us were resistant to most of the antibiotics, sir. Thank you, sir.